Question 1. Mr. Williams is a 45-year-old male who has been diagnosed with obstructive sleep apnea (OSA). His polysomnographic results show an apnea-hypopnea index a high of 30 events per hour, with oxygen desaturation to 88% during episodes of apnea. Mr. Williams has been prescribed CPAP therapy, but he is struggling with adherence. His physician is considering alternative treatments based on the severity of condition and his struggle with CPAP adherence. What is the next appropriate management step for Mr. Williams? A. Continue CPAP therapy with increased pressure settings. B. Initiate bilevel PAP, BiPAP therapy. C. Recommend surgery such as uvulopharyngoplasty. D. Consider oral appliance therapy mandibular advancement device. Answer: B. Initiate bilevel PAP, BiPAP therapy. Explanation: in this case, Mr. Williams has moderate severe obstructive sleep apnea (OSA) evidenced by an R high of 30 and significant oxygen desaturation. CPAP is typically the first line of treatment for OSA, but the patient's non-adherence is a common issue. Bilevel PAP, BiPAP therapy is a viable alternative for patients who struggle with CPAP adherence, as it provides more pressure variation during inhalation and exhalation. The pressure support of BiPAP is especially useful for patients who have difficulty with the constant pressure provided by CPAP. Option: continue CPAP with increased pressure may not resolve the adherence issue. Option C: surgery such as UP is typically considered after failed non-invasive therapies, especially in patients with significant airway obstruction. Option D: oral appliance therapy is appropriate for mild to moderate OSA but may not be effective in severe cases like Mr. Williams. Question 2. Which of the following is not a characteristic of sleep-disordered breathing (SDB) in children? A. Increased risk of behavioral problems and learning difficulties. B. Common occurrence of central sleep apnea. C. Frequent daytime sleepiness or fatigue. D. Association with growth disturbances such as failure to thrive. Answer: B. Common occurrence of central sleep apnea. Explanation: sleep-disordered breathing (SDB) in children is most often characterized by obstructive sleep apnea (OSA), not central sleep apnea. Obstructive sleep apnea is commonly associated with enlarged tonsils and adenoids, which can lead to partial or complete airway obstruction during sleep. This condition is linked to increased risk of behavioral problems, learning difficulty, daytime sleepiness, C, and growth disturbances, D, like failure to thrive, as the child experiences interrupted sleep and inadequate oxygenation. Central sleep apnea, which involves the absence of respiratory effort, is less common in children and typically associated with neurological conditions, making it the least characteristic feature of SDB in children. Question 3. A 55-year-old female patient presents with complaints of chronic insomnia, reporting difficulty falling asleep and waking up frequently throughout the night. She also mentions that she has recently started experiencing anxiety due to a stressful work environment. After completing a sleep diary and screening for other medical conditions, her physician suspects her insomnia is secondary to anxiety. What is the most appropriate first-line treatment for this patient? A. Prescribe benzodiazepines for immediate relief. B. Initiate cognitive behavioral therapy for insomnia (CBTI). C. Recommend over-the-counter melatonin supplements. D. Start a selective serotonin reuptake inhibitor (SRI) for anxiety. Answer: B. Initiate cognitive behavioral therapy for insomnia (CBEI). Explanation: chronic insomnia that is secondary to a psychiatric condition such as anxiety should be initially treated with cognitive behavioral therapy for insomnia (CBTA). CBTI is considered the first-line treatment for chronic insomnia, especially in the context of comorbid anxiety. This therapy addresses the cognitive and behavioral patterns, perpetuate insomnia, promoting long-term improvements in sleep without the risk of medication dependence. Option was benzodiazepines may provide short-term relief, but they are not recommended as a long-term solution due to the risk of dependence and adverse effects. Option C, melatonin, is not typically effective for chronic insomnia unless there is a specific circadian rhythm disorder. Option D, SRI for anxiety, might be appropriate if the primary concern is anxiety. However, CBTI should be the first treatment approach for insomnia. Question 4. Mr. Thomas, a 52-year-old male, presents with complaints of excessive daytime sleepiness and loud snoring at night. His wife reports that he frequently stops breathing during sleep, and he has been waking up with a dry mouth and sore throat. Mr. Thomas has a history of hypertension and obesity. A home sleep apnea test, HSAT, was performed, and it revealed an apnea-hypopnea index a high of 45 events per hour. Oxygen desaturation to 85%. Based on this information, which of the following would be the most appropriate initial treatment for Mr. Thomas? A. Initiate continuous positive airway pressure CPAP therapy. B. Recommend surgery such as uvulopalaropharyngoplasty. C. Prescribe a pharmacological agent for excessive daytime sleepiness. D. Suggest lifestyle modifications such as weight loss and positional therapy. Answer A. Initiate continuous positive airway pressure CPAP therapy. Explanation: Mr. Thomas has moderate to severe obstructive sleep apnea (OSA) as indicated by his AHI of 45 events per hour and oxygen desaturation to 85%. CPAP is the first-line treatment for OSA, particularly in patients with moderate to severe disease. CPAP works by providing a constant airflow through the airway, preventing collapse during sleep. Option B, surgery such as UP, is typically reserved for patients with refractory OSA after failed non-invasive treatments. Option C, pharmacological agent, would not address the root cause of Mr. Thomas' sleep apnea and is generally not recommended for OSA. Option D, lifestyle modifications, are important for overall management but would not be sufficient as a standalone treatment in severe cases like Mr. Thomas. Question 5. A 36-year-old woman presents with complaints of insomnia that has been affecting her for several months. She reports difficulty falling asleep, waking up multiple times during the night, and feeling tired throughout the day. She has no significant medical or psychiatric history. Upon further questioning, she mentions that she works irregular night shifts and has recently started traveling across time zones for work. Which of the following is the most likely diagnosis and what is the most appropriate treatment approach? A. Primary insomnia. Prescribe a benzodiazepine for short-term use. B. Delayed sleep phase disorder. You recommend light therapy in the morning. C. Shift work disorder. Initiate chronotherapy and consider melatonin supplementation. D. Insomnia secondary to anxiety. Start cognitive behavioral therapy for insomnia CBTI. Answer C. Shift work disorder. Initiate chronotherapy and consider melatonin supplementation. Explanation: This patient's insomnia is most likely secondary to shift work disorder, condition that occurs when person's circadian rhythm is misaligned due to irregular work hours, particularly night shifts. Chronotherapy, which involves gradually adjusting sleep times to align with the desired sleep-wake schedule, and melatonin supplementation, which regulate the circadian rhythm, are the most effective treatment options. Option: primary insomnia is less likely because the patient's insomnia appears related to her work schedule. Option B, delayed sleep phase disorder, typically involves delay in the sleep-wake cycle, but this patient's work schedule is more likely cause. Option D, insomnia secondary to anxiety, is less likely given the absence of significant anxiety symptoms. Question 6. Mrs. Hernandez, a 70-year-old female, has been experiencing difficulty staying asleep at night. She wakes up several times, especially around early morning, and finds it difficult to fall back asleep. She also reports feeling restless in her legs, especially at night. A family history of restless leg syndrome, RLS, is noted. Her physician suspects that RLS may be contributing to her sleep disturbances. What is the first pharmacological treatment for RLS in this patient? A. Dopamine agonists, e.g. pramixole or rapinirole. B. Antidepressants, e.g. Eseris. C. Opioids, e.g. oxycodone. D. Benzodiazepines, e.g. lorazepam. Answer A. Dopamine agonists, e.g. pramixole or rapinirole. Explanation: Restless leg syndrome. RLS is typically treated with dopamine agonists such as pramixole or rapinirole, which help alleviate the symptoms of leg restlessness by stimulating dopamine receptors in the brain. These medications are considered the first-line pharmacological treatment for RLS. Option B, antidepressants are not effective for RLS and can worsen sleep quality. Option C, opioids are not first-line treatments for RLS due to the risk of dependency and side effects. Option D, benzodiazepines may help with sleep but do not address the core symptoms of RAS. Question 7. A 50-year-old man with a history of hypertension and type 2 diabetes is referred for a sleep study due to his complaints of snoring, choking episodes, and excessive daytime sleepiness. Polysomnography reveals an AHI of 35 with a significant number of hypopneas and oxygen desaturation. The patient's physician is concerned about the potential cardiovascular consequences of untreated sleep apnea. Which of the following the most appropriate long-term management plan for this patient? A. Initiate CPAP therapy and recommend lifestyle changes such as weight loss. B. Recommend surgery, G. Up to improve airway patency. C. Start an antihypertensive medication to manage blood pressure. D. Prescribe stimulant for daytime sleepiness. Answer A. Initiate CPAP therapy and recommend lifestyle changes such as weight loss. Explanation. This patient has moderate to severe obstructive sleep apnea (OSA) as evidenced by an OHI of 35 and oxygen desaturation. The most appropriate treatment is continuous positive airway pressure (CPAP) therapy, which will help maintain airway patency during sleep and prevent cardiovascular complications associated with untreated OSAs, hypertension and heart failure. Lifestyle changes, such as weight loss, are also crucial in managing OSA and reducing its cardiovascular risks. Option B, surgery, is usually reserved for patients who do not respond to CPAP therapy or those with specific anatomical abnormalities. Option C, antihypertensive medication, addresses hypertension but does not treat the underlying sleep apnea. Option D, stimulant for daytime sleepiness might help with the symptoms of excessive daytime sleepiness, but it does not address the root cause of the condition. Question 8. A 32-year-old woman presents with complaints of feeling excessively sleepy during the day and having difficulty staying awake, especially during meetings or while driving. She experiences a sudden, irresistible urge to sleep, sometimes even while talking to people. The episodes are short, lasting only a few minutes, but they occur several times throughout the day. She has no significant medical or psychiatric history. Based on the likely diagnosis, what is the first-line treatment? A. Initiate stimulant therapy, G. Modafinil. B. Prescribe a sedative hypnotic, G. Zolpidem for nighttime sleep. C. Start cognitive behavioral therapy for insomnia, CBTI. D. Recommend an increase in caffeine intake during the day. Answer A. Initiate stimulant therapy, G. Modafinil. Explanation. The patient is exhibiting symptoms consistent with narcolepsy, particularly excessive daytime sleepiness and cataplexy, a sudden loss of muscle tone triggered by strong emotions such as laughing. The first-line treatment for narcolepsy includes the use of stimulant medications such as modafinil or amphetamines to promote wakefulness and reduce daytime sleepiness. Option B, sedative hypnotics, would not be appropriate for daytime sleepiness and would not address the underlying issue of narcolepsy. Option C, CBTI, is effective for insomnia but not for narcolepsy, which is a neurological disorder. Option D, increased caffeine intake, may provide temporary relief but is not a suitable long-term solution for narcolepsy. Question 9. A 47-year-old male presents with chronic insomnia. He reports difficulty falling asleep due to racing thoughts and worries about his work and finances. He has been experiencing these symptoms for several months and is finding it difficult to cope with the lack of sleep. He is considering pharmacological treatment options. What is the most appropriate initial treatment for his insomnia given the probable underlying cause? A. Cognitive behavioral therapy for insomnia, CBTI. B. Prescribe a benzodiazepine. G. Diazepam for sleep. C. Start an antidepressant. E. G. Sertraline for his anxiety symptoms. D. Recommend over-the-counter sleep aid. C. G. Diphenhydramine. Answer A. Cognitive behavioral therapy for insomnia, CBTI. Explanation. In cases of insomnia with underlying anxiety or cognitive distress, cognitive behavioral therapy for insomnia, CBTI, is the most appropriate initial treatment. CBTI addresses both the psychological and behavioral factors that contribute to insomnia and has been shown to provide long-term benefits without the risks associated with pharmacological treatments. Option B, benzodiazepine, is not recommended for chronic insomnia due to the potential for dependency and tolerance. Option C, antidepressants may be appropriate for anxiety, but CBTI should be the first-line treatment for insomnia. Option D, ultra sleep aids can provide short-term relief but do not address the underlying causes of insomnia. Question 10. A 64-year-old woman with a history of diabetes mellitus and hypertension presents to the clinic with complaints of frequent awakenings during the night, particularly after feeling her heart racing. She describes feeling increasingly anxious and nervous, particularly during the night. Upon questioning, she reports that she has been experiencing episodes of chest discomfort that resolve spontaneously but last for a few minutes. There is a history of angina or shortness of breath. Which of the following is the most likely diagnosis and what is the best next step in management? A. Panic disorder. Initiate selective serotonin reuptake inhibitors, SRIs. B. Generalized anxiety disorder. Recommend cognitive behavioral therapy, CBT. C. Nocturnal angina. Schedule a stress test. D. Obstructive sleep apnea order polysomnography. Answer A. Panic disorder. Initiate selective serotonin reuptake inhibitors, SRIS. Explanation. Is patients' episodes of chest discomfort, racing heart, and anxiety are suggestive of panic attacks, which are common in panic disorder. Panic attacks typically occur suddenly, often at night, and may include chest discomfort, tachycardia, and sense of impending doom. The best next step is to initiate SRIS, which are first-line pharmacological treatment. For panic disorder, Option B, generalized anxiety disorder, is possible differential, but the sudden onset of symptoms and a nocturnal pattern are more characteristic of panic disorder. Option C, nocturnal angina, is less likely due to the absence of risk factors like coronary artery disease and absence of typical anginal symptoms. Option D, obstructive sleep apnea, is potential differential, but the patient's symptoms are more suggestive of anxiety and panic attacks rather than OSA. Question 11. A 45-year-old man with a history of obesity, hypertension, and type 2 diabetes presents with complaints of chronic insomnia. He reports trouble falling asleep and waking up multiple times throughout the night, often feeling unrefreshed upon awakening. He has tried over-the-counter sleep aids with little effect. His physician is concerned about the possibility of sleep-disordered breathing and decides to perform a sleep study. Polysomnography reveals an AHI of 25 with oxygen desaturation during the night. What is the most appropriate treatment for this patient? A. Recommend weight loss and initiate continuous positive airway pressure (CPAP) therapy. B. Initiate behavioral therapy for insomnia. C. Prescribe zolpidem to help with sleep initiation. D. Recommend surgery such as uvulopalato-pharyngoplasty. Answer A. Recommend weight loss and initiate continuous positive airway pressure (CPAP) therapy. Explanation. This patient's polysomnography results are indicative of moderate obstructive sleep apnea, OSA, which is commonly seen in individuals with obesity. The most appropriate treatment involves CPAP therapy to prevent airway collapse during sleep and weight loss to reduce the severity of OSA. CPAP is the gold standard for moderate to severe OSA. Option B, behavioral therapy for insomnia, would address the insomnia but would not treat the underlying OSA, which is causing the sleep disruption. Option C, zolpidem, could be used for short-term insomnia management but does not address the underlying issue of OSA. Option D, surgery, is generally considered only after CPAP fails or if anatomical issues are found. Question 12. A 28-year-old woman presents with complaints of insomnia for the past several months. She reports that she struggles to fall asleep, often staying awake for hours. She also wakes up early in the morning and cannot get back to sleep. She works a 9-to-5 job and has no significant medical or psychiatric history. Upon further questioning, she reveals that she has been feeling depressed and has lost interest in activities she once enjoyed. Which of the following is the most likely diagnosis and what is the most appropriate treatment? A. Primary insomnia. Start a benzodiazepine. B. Depression with comorbid insomnia. Initiate an antidepressant. C. Sleep apnea, order polysomnography. D. Chronic stress. Recommend relaxation techniques. Answer. B. Depression with comorbid insomnia. Initiate an antidepressant. Explanation. This patient's insomnia, combined with symptoms of depression, loss of interest, mood changes, suggests that she may have depression with comorbid insomnia. Antidepressants such as selective serotonin reuptake inhibitors, SRIS, or serotonin norepinephrine reuptake inhibitors, NRIS, are often first-line treatments for both depression and insomnia in such cases. Option as a primary insomnia is less likely, as the insomnia is likely secondary to depression. Option C, sleep apnea, is less likely given the absence of typical symptoms of sleep-disordered breathing, such as snoring or choking during sleep. Option D, chronic stress, could be a contributing factor, but the presence of depressive symptoms points to a mood disorder as the primary cause. Question 13. A 55-year-old man with a long-standing history of alcohol use disorder presents to the emergency department with complaints of severe agitation, confusion, and tremors. He was admitted to the hospital 24 hours ago after being detoxified from alcohol. His heart rate is 110 bpm. Blood pressure is 140/85 mmHg and his temperature is 37.8 deg. His coma scale score is 14 and he appears disoriented to time and place. Which of the following is the most appropriate next step in management? A. Administer lorazepam and monitor for signs of delirium tremens. B. Initiate phenytoin to prevent seizures. C. Start haloperidol to manage agitation. D. Provide supportive care and rehydrate the patient. Answer A. Administer lorazepam and monitor for signs of delirium tremens. Explanation. This patient is presenting with symptoms consistent with alcohol withdrawal, including agitation, tremors, confusion, and autonomic instability. The most appropriate next step is to administer lorazepam or another benzodiazepine to manage withdrawal symptoms and prevent complications such as delirium tremens, which can occur in severe alcohol withdrawal cases. Option B, phenytoin, is used for seizure prevention but is not the first-line treatment for alcohol withdrawal. Option C, haloperidol, is not recommended for alcohol withdrawal as it may worsen the condition and increase the risk of seizures. Option D, supportive care and rehydration, is important but does not address the acute need for medication to manage withdrawal symptoms. Question 14. A 29-year-old woman presents with complaints of frequent headaches that are associated with nausea, photophobia, and a sensitivity to sound. She reports that the headaches tend to occur once or twice a month and last for several hours. She also mentions that she has been experiencing neck stiffness and a feeling of fatigue. Her physical exam is unremarkable, and she does not have any significant medical or psychiatric history. The most likely diagnosis and what is the best initial treatment? A, tension-type headache, initiate over-the-counter analgesics. B, migraine, prescribe triptans for acute headache relief. C, cluster headache, prescribe oxygen therapy. D, cervicogenic headache, refer for physical therapy. Answer: B, migraine, prescribe triptans for acute headache relief. Explanation: this patient presents with features typical of a migraine, including headaches associated with nausea, photophobia, and sensitivity to sound. The best initial treatment for acute migraines is a triptan, which works by constricting blood vessels and alleviating pain. Option with tension-type headache typically presents with a dull bilateral headache and is less likely to cause nausea and photophobia. Option C, cluster headache, is characterized by severe unilateral headaches typically occurring around the eye and associated with autonomic symptoms e.g. tearing, nasal congestion. Option D, cervicogenic headache, is related to neck pain and movement, which is not reported in this case. Question 15. A 63-year-old man with a history of obesity and hypertension presents to the clinic with complaints of excessive daytime sleepiness. His wife reports that he snores loudly at night and occasionally stops breathing during sleep. He also has frequent headaches upon awakening and experiences dry mouth and sore throat in the mornings. Polysomnography confirms moderate obstructive sleep apnea, OSA. Which of the following is the appropriate long-term management plan for this patient? A, recommend weight loss and initiate continuous positive airway pressure CPAP therapy. B, initiate surgical intervention such as uvulopalatalpharyngoplasty. C, start pharmacological agents for daytime sleepiness e.g. modafinil. D, advise the patient to use over-the-counter sleep aids e.g. diphenhydramine. Answer: A, recommend weight loss and initiate continuous positive airway pressure CPAP therapy. Explanation: the best treatment for moderate obstructive sleep apnea OSA is continuous positive airway pressure CPAP therapy, which will help maintain the airway open during sleep. Additionally, weight loss is an important adjunct to managing OSA in obese patients. Option B, surgical intervention, is generally considered after CPAP fails or when anatomical issues contribute to OSA. Option C, pharmacological agents might help with daytime sleepiness but will not address the underlying sleep-disordered breathing. Option D, ultrasleep aids, are not effective in treating OSA and are not recommended as a long-term solution. Question 16. A 48-year-old woman presents with difficulty sleeping, often waking up multiple times during the night and feeling unrested in the morning. She reports significant stress at work and family issues which have been ongoing for several months. She has no significant medical or psychiatric history. Based on the most likely diagnosis, what is the most appropriate management? A, start cognitive behavioral therapy for insomnia CBTI. B, prescribe benzodiazepines for short-term sleep relief. C, initiate pharmacological treatment for generalized anxiety disorder GAD. D, recommend lifestyle modifications and over-the-counter sleep aids. Answer: A, start cognitive behavioral therapy for insomnia CBTI. Explanation: this patient likely has insomnia secondary to stress, which is commonly treated with cognitive behavioral therapy for insomnia CBTI. CBTI helps patients identify and change behaviors and thoughts that contribute to poor sleep, making it an effective long-term treatment. Option B, benzodiazepines, should only be used short-term due to the risk of dependency. Option C, pharmacological treatment for GAD, is unnecessary without a clear diagnosis of generalized anxiety disorder. Option D, lifestyle modifications and OCA sleep aids are helpful but not as effective as CBTI for long-term insomnia management. Question 17. A 70-year-old woman presents with complaints of excessive daytime sleepiness. She has a history of Parkinson's disease and recently noticed that her sleep patterns have become more disrupted. She often wakes up multiple times during the night and has vivid dreams. Her caregiver reports that she frequently experiences sudden muscle weakness when laughing. What is the most likely diagnosis and what is the best next step in management? A. Parkinson's disease with REM sleep behavior disorder. Initiate clonazepam. B. Alzheimer's disease with disrupted sleep patterns. Start acetylcholinesterase inhibitors. C. Narcolepsy. Initiate stimulant therapy. G. Modafinil. D. Obstructive sleep apnea. Initiate CPAP therapy. Answer A. Parkinson's disease with REM sleep behavior disorder. Initiate clonazepam. Explanation. Is patient symptoms of vivid dreams, sleep disturbances, and muscle weakness triggered by laughter are suggestive of REM sleep behavior disorder, RBD, which is commonly associated with Parkinson's disease. Clonazepam is the first-line treatment for RBD as it helps control abnormal behaviors during REM sleep. Option B. Alzheimer's disease is less likely as the primary cause of sleep disturbances and the patient's symptoms of muscle weakness do not align with Alzheimer's. Option C. Narcolepsy does not fit this patient's symptoms, as narcolepsy is characterized by excessive daytime sleepiness with cataplexy but without REM sleep behavior disorder. Option D. Obstructive sleep apnea does not fit the symptoms as clearly as RBD in the context of Parkinson's disease. Question 18. A 40-year-old woman with a history of anxiety presents with complaints of frequent awakenings during the night and difficulty falling asleep. She reports that her mind races with worries about her family and job. These symptoms have been ongoing for several months and have significantly impacted her quality of life. What is the most appropriate first-line treatment for her insomnia? A. Initiate cognitive behavioral therapy for insomnia CBTI. B. Prescribe a benzodiazepine for short-term use. C. Start an antidepressant. E. G. Sertraline. D. Recommend over-the-counter antihistamines for sleep. Answer A. Initiate cognitive behavioral therapy for insomnia CBEI. Explanation. CBTI is the most appropriate first-line treatment for insomnia, especially when it is secondary to anxiety. CBTI is effective in improving sleep quality by addressing the thoughts and behaviors contributing to poor sleep. Option B. Benzodiazepines are generally not recommended for chronic insomnia due to their potential for dependency. Option C. Antidepressant could be useful if the patient's anxiety is significantly contributing to her insomnia, but CBTI should still be the first approach. Option D. OCA antihistamines can be helpful in the short term, but do not address the underlying cause of insomnia. Question 19. A 34-year-old man with a history of anxiety presents to the emergency department with chest pain, palpitations, and shortness of breath. His symptoms started suddenly while he was sitting at his desk at work. He describes a feeling of intense fear and a racing heart. He denies any recent trauma, excessive alcohol intake, or a history of heart disease. His vitals are heart rate 115 EPM, blood pressure 130/85 mmHg, and respiratory rate 22 breaths/min. An ECG shows normal sinus rhythm. Which of the following is the most likely diagnosis and what is the best next step in management? A. Panic attack to reassure and educate the patient about anxiety. B. Myocardial infarction. Initiate aspirin and call for cardiology consultation. C. Pulmonary embolism. Obtain a pulmonary angiogram. D. Acute anxiety disorder. Initiate a short course of benzodiazepine therapy. Answer A. Panic attack to reassure and educate the patient about anxiety. Explanation. This patient is presenting with classic symptoms of a panic attack, which can include chest pain, palpitations, and shortness of breath. Panic attacks often occur suddenly and are associated with intense fear and physical symptoms. The best next step is to reassure the patient, educate them about anxiety, and provide strategies for managing future attacks. Relaxation techniques. Option B. Myocardial infarction is unlikely given the patient's young age and lack of traditional cardiovascular risk factors. Option C. Pulmonary embolism is unlikely because the patient's symptoms do not include pleuristic chest pain or risk factors for embolism. Option D. Acute anxiety disorder would be a consideration, but the patient's acute distress and physical symptoms are more consistent with panic attack rather than chronic anxiety disorder. Question 20. A 55-year-old woman with a history of hypertension and diabetes presents with a complaint of progressively worsening shortness of breath, especially when lying flat. She also reports swelling in her ankles and legs. On physical examination, she has bilateral pitting edema up to the knees, jugular venous distension (JVD), and crackles on lung auscultation. An echocardiogram shows a reduced ejection fraction of 35%. What is the most likely diagnosis and what is the best next step in management? A. Acute respiratory distress syndrome. ARDS. Administer mechanical ventilation. B. Chronic obstructive pulmonary disease, COPD exacerbation. Administer bronchodilators. C. Congestive heart failure. Initiate diuretic therapy. D. Pulmonary embolism. Start anticoagulation therapy. Answer: C. Congestive heart failure. Initiate diuretic therapy. Explanation: this patient's presentation of progressive shortness of breath, orthopnea, lower extremity edema (JVD), and crackles on auscultation is consistent with congestive heart failure (CHF), particularly with the reduced ejection fraction of 35%. The best next step in management is to initiate diuretic therapy to relieve fluid overload and reduce symptoms. Heart failure. Option: ARDS typically presents with acute respiratory failure and hypoxemia in critically ill patient, not with chronic symptoms. Option B, COPD exacerbation, is unlikely given the lack of smoking history and the patient's heart failure symptoms. Option D, pulmonary embolism, is less likely given the chronicity of symptoms and the presence of heart failure signs. Question 21. A 45-year-old man with a history of chronic alcohol use presents to the clinic with tremors, nausea, and confusion. He has not consumed alcohol for the past 48 hours. His blood pressure is 145/9 heart rate is 120 bpm, and temperature is 37.5 Dick. On examination, he has caused tremors in both hands, agitation, and confusion. Which of the following is the most likely diagnosis and what is the best next step in management? A. Alcohol withdrawal syndrome. Initiate benzodiazepine therapy. B. Hypoglycemia. Administer intravenous glucose. C. Delirium tremens. Start thiamine supplementation and benzodiazepines. D. Sepsis. Start broad-spectrum antibiotics. Answer: C. Delirium tremens. Start thiamine supplementation and benzodiazepines. Explanation: this patient is showing signs of delirium tremens. D. A severe form of alcohol withdrawal that can occur 4-8-7-2 hours after the last drink. Symptoms include agitation, confusion, tremors, and autonomic instability. The best treatment involves starting benzodiazepines to manage withdrawal symptoms along with thiamine supplementation. Prevent Werner-Korsakoff syndrome, which can result from thiamine deficiency during alcohol withdrawal. Option called alcohol withdrawal syndrome is a broader term, and DT is a severe form of withdrawal requiring more intensive management. Option B, hypoglycemia, is unlikely given the patient's history of alcohol use and the more specific signs of withdrawal. Option D, sepsis, does not explain the patient's signs and symptoms, which are more consistent with alcohol withdrawal. Question 22. A 62-year-old man with a history of hypertension, smoking, and hyperlipidemia presents to the emergency department with sudden onset severe chest pain radiating to his back. His vital signs are heart rate 105 bpm, blood pressure 179 Hg, and respiratory rate 20 breaths/min. A chest X-ray shows a widened mediastinum. What is the most likely diagnosis and is the best next step in management? A. Acute myocardial infarction. Initiate aspirin, heparin, and call for cardiology. B. Aortic dissection. Order her angiogram of the chest. C. Pulmonary embolism. Order her pulmonary angiogram. D. Gastroesophageal reflux disease (GERD). Administer proton pump inhibitors. Answer: B. Aortic dissection. Order a angiogram of the chest. Explanation: this patient's sudden onset chest pain radiating to his back along with a widened mediastinum on chest X-ray is highly suggestive of an aortic dissection. The next best step is to order an angiogram of the chest to confirm the diagnosis and evaluate the extent of the dissection. Optional acute myocardial infarction is less likely due to the sudden and radiating pain characteristic of aortic dissection rather than typical anginal pain. Option C, pulmonary embolism, is unlikely given the absence of typical symptoms like shortness of breath and hypoxia. Option D, GERD, is unlikely because the patient's chest pain is sudden, severe, and radiates, which is not typical of GERD. Question 23. A 25-year-old woman presents with A complaint of chronic relapsing headaches for the past year. The headaches are usually unilateral and associated with nausea, photophobia, and sensitivity to sound. She reports that they often occur around the time of her menstrual cycle. What is the most likely diagnosis and what is the best treatment? A. Cluster headaches. It prescribes sumatriptan and oxygen. B. Tension-type headaches. It recommends stress reduction techniques. C. Migraine headaches. It initiate abortive therapy with triptans. D. Sinusitis. It prescribe intranasal corticosteroids. Answer: C. Migraine headaches. It initiate abortive therapy with triptans. Explanation: this patient's symptoms of unilateral throbbing headaches associated with nausea, photophobia, and a relationship to her menstrual cycle suggest migraines. The best treatment for acute migraines is abortive therapy with triptans, which help relieve pain and associated symptoms. Option were cluster headaches, typically present with excruciating unilateral pain around the eye and autonomic symptoms such as tearing or nasal congestion. Option B, tension-type headaches, are usually bilateral and have a band-like quality without nausea or photophobia. Option D, sinusitis, typically presents with facial pain, congestion, and purulent nasal discharge, which is not consistent with this patient's symptoms. Question 24. A 58-year-old woman with a history of diabetes and hypertension presents to the clinic for a routine checkup. She reports that her vision has been gradually worsening over the past few months and she has difficulty seeing at night. On examination, her blood pressure is 140/85 mmHg and her blood glucose level is 200 mdl. Endoscopic examination reveals microaneurysms, retinal hemorrhages, and cotton wool spots. What is the most likely diagnosis and what is the best next step in management? A. Diabetic retinopathy. Refer for ophthalmology evaluation and control blood sugar. B. Age-related macular degeneration. Initiate antioxidant therapy. C. Retinal vein occlusion. Start intravitreal anti-VEGF therapy. D. Hypertensive retinopathy. Initiate blood pressure control. Answer A. Diabetic retinopathy. Refer for ophthalmology evaluation and control blood sugar. Explanation: this patient has signs of diabetic retinopathy, including microaneurysms, retinal hemorrhages, and cotton wool spots. The best next step is to refer her for an ophthalmology evaluation for possible treatment, along with efforts to better control her blood glucose and blood pressure to prevent further retinal damage. Option B, age-related macular degeneration, is less likely due to the absence of drusen or central vision loss. Option C, retinal vein occlusion, typically presents with sudden vision loss, which this patient does not have. Option D, hypertensive retinopathy, could present with similar findings but does not explain the patient's history of diabetes. Question 25. A 45-year-old woman presents to the emergency department with severe abdominal pain in the right lower quadrant that began suddenly 4 hours ago. She also reports nausea and vomiting. Her last menstrual period was 2 weeks ago. She has a history of irregular menstrual cycles. On examination, she has tenderness in the right lower quadrant and her vital signs are heart rate 110 bpm, blood pressure 106 mmHg, and temperature 37.8 deg. Urine pregnancy test is positive. What is the most likely diagnosis and what is the next step in management? A. Acute appendicitis. Obtain CT scan of the abdomen. B. Ovarian torsion. Perform pelvic ultrasound. C. Ectopic pregnancy. Obtain an ultrasound and Surishiji. D. Pelvic inflammatory disease. Start broad spectrum antibiotics. Answer B. Ovarian torsion. Perform a pelvic ultrasound. Explanation: this patient is presenting with acute severe right lower quadrant abdominal pain, nausea, vomiting, and a positive pregnancy test. The most likely diagnosis is ovarian torsion, a gynecological emergency where the ovary twists on its blood supply, causing pain. The best next step is to perform a pelvic ultrasound to confirm the diagnosis and evaluate for the present torsion or an ovarian mass. Optional acute appendicitis is less likely because the pain is more localized to the right lower quadrant and the patient's symptoms are more acute in onset with positive pregnancy test. Option C, ectopic pregnancy, is also consideration, especially in women of reproductive age with abdominal pain and positive pregnancy test. However, ovarian torsion is more likely cause of the pain in this case. Option D, pelvic inflammatory disease, is less likely due to the sudden and severe onset of pain and the absence of fever and cervical motion tenderness. Question 26. A 72-year-old man with a history of heart failure with reduced ejection fraction, HREF, presents to the clinic with complaints of increasing shortness of breath, orthopnea, and paroxysmal nocturnal dyspnea over the past week. He also reports fatigue and decreased appetite. His blood pressure is 130/85 mmHg, heart rate is 90 EM, and he has bilateral lower extremity edema. On physical examination, his lungs reveal crackles, and there is an S-heart sound. What is the most likely diagnosis, and what is the best next step in management? A. Acute decompensated heart failure. Increase diuretics and optimize heart failure medications. B. Chronic obstructive pulmonary disease, COPD exacerbation. Initiate bronchodilators and corticosteroids. C. Pulmonary embolism. Start anticoagulation therapy. D. Pneumonia. Prescribe antibiotics and consider oxygen therapy. Answer A. Acute decompensated heart failure. Increase diuretics and optimize heart failure medications. Explanation. This patient with a history of HREF and symptoms of worsening shortness of breath, orthopnea, paroxysmal nocturnal dyspnea, bilateral edema, and an heart sound is most likely experiencing acute decompensated heart failure. The best next step is to increase the dose of diuretics to manage fluid overload and optimize heart failure medications. ACE inhibitors, beta blockers, or aldosterone antagonists to prevent further decompensation. Option B, COPD exacerbation, is less likely due to the lack of wheezing or a history of smoking-related lung disease. Option C, pulmonary embolism, is unlikely without signs of hypoxia, pleuritic chest pain, or risk factors for thromboembolism. Option D, pneumonia, is less likely given the patient's history and clinical findings, which are more suggestive of heart failure. Question 27. A 29-year-old woman presents with a complaint of a new irregular mole on her right arm that has changed in appearance over the past few months. The mole is asymmetric, has irregular borders, and is darker than her other moles. She also reports that it has been itching and bleeding occasionally. On examination, the mole is 1.5 centimeters in diameter with the described irregularities. What is the most likely diagnosis and what is the best next step in management? A. Basal cell carcinoma. Perform a punch biopsy. B. Squamous cell carcinoma. Perform a shave biopsy. C. Melanoma. Perform an excisional biopsy. D. Seborrheic keratosis. Reassure and observe. Answer. C. Melanoma. Perform an excisional biopsy. Explanation. This patient's mole has features that are highly suspicious for melanoma, including asymmetry, irregular borders, color variation, and recent changes in size, shape, or bleeding. The best next step in management is to perform an excisional biopsy to obtain full sample of the lesion for histopathological evaluation. Option: basal cell carcinoma usually presents as pearly nodular lesion, not with irregular borders and color changes. Option B, squamous cell carcinoma typically presents as rough, scaly lesion rather than apigmented lesion with irregular borders. Option D, seborrheic keratosis is usually benign, well-defined lesion with stuck-on appearance and is not typically associated with changes in color or bleeding. Question 28. A 40-year-old man with a history of type 2 diabetes presents to the clinic for a routine checkup. He reports that he has been feeling more fatigued than usual and has noticed increased thirst and frequent urination. His blood pressure is 135/85 mmHg and his blood glucose level is 230. A urine dipstick test reveals 2 glucose and no ketones. What is the most diagnosis and what is the best next step in management? A. Diabetic ketoacidosis. Admit for intravenous fluids and insulin therapy. B. Hyperosmolar hypoglycemic state. Initiate intravenous fluids and insulin. C. Uncontrolled type 2 diabetes. Optimize diabetes management with lifestyle modifications and medications. D. Acute kidney injury. Assess renal function and consider nephrology referral. Answer. C. Uncontrolled type 2 diabetes. Optimize diabetes management with lifestyle modifications and medications. Explanation. This patient with a history of type 2 diabetes, elevated blood glucose polyuria, and polydipsia is likely experiencing uncontrolled diabetes. The next step is to optimize diabetes management through a combination of lifestyle changes, diet and exercise, and medications such as hypoglycemics or insulin. Option with diabetic ketoacidosis is unlikely since the patient does not have significant symptoms such as nausea, vomiting, or ketonuria. Option B, hyperosmolar hypoglycemic state, is unlikely as the patient does not have severe hypoglycemia or signs of dehydration. Option D, acute kidney injury, is less likely as there is no significant history of renal dysfunction or a marked increase in creatinine. Question 29. A 50-year-old man with a history of heavy alcohol use presents with confusion, ataxia, and ophthalmoplegia. He has a history of poor dietary intake and has been neglecting his nutrition recently. His vital signs are normal, and his neurological exam reveals nystagmus, ataxia, and difficulty with coordination. What is the most likely diagnosis and what is the next step in management? A. Wernicke's encephalopathy. Administer thiamine and avoid glucose administration without thiamine. B. Delirium tremens. Start benzodiazepines and monitor in controlled setting. C. Acute alcohol intoxication. Provide hydration and supportive care. D. Cerebellar stroke. Obtain MRI of the brain. Answer A. Wernicke's encephalopathy. Administer thiamine and avoid glucose administration without thiamine. Explanation. This patient presents with classic signs of Wernicke's encephalopathy, neurological disorder caused by thiamine deficiency, most often seen in alcoholics. The next step is to administer thiamine intravenously before any glucose administration to prevent precipitating or worsening the condition. Option B, delirium tremens, is consideration in alcohol withdrawal but does not explain the neurological signs like nystagmus and ataxia. Option C, acute alcohol intoxication, would not explain the chronic neurological deficit seen in this patient. Option D, cerebellar stroke, could present with ataxia but would not explain the other symptoms of confusion and ophthalmoplegia which point toward Wernicke's encephalopathy. Question 30. A 60-year-old woman with a history of hypertension and hyperlipidemia presents to the clinic with a complaint of a persistent dry cough that has been bothering her for the past 3 months. She reports no other symptoms such as fever, shortness of breath, or chest pain. She is currently taking an ACE inhibitor for her hypertension. What is the most likely cause of her symptoms and what is the best next step in management? A. Asthma. Perform spirometry and start bronchodilators. B. Chronic bronchitis. It recommends smoking cessation and prescribe inhaled corticosteroids. C. ACE inhibitor-induced cough. Switch to an angiotensin to receptor blocker ARB. D. Postnasal drip. Treat with antihistamines and decongestants. Answer. C. ACE inhibitor-induced cough. Switch to an angiotensin to receptor blocker ARB. Explanation. This patient's persistent dry cough, which started after starting an ACE inhibitor, is most likely due to the common side effect of ACE inhibitors. The best next step is to switch the patient to an angiotensin to receptor blocker ARB, which has similar effect on blood pressure but does not cause the cough. Option asthma is less likely without history of wheezing, shortness of breath, or allergy symptoms. Option B, chronic bronchitis, is unlikely without smoking history or chronic productive cough. Option D, postnasal drip, is possible but less likely given the lack of other upper respiratory symptoms.